thanks so much once again, Prof, for really having this necessary conversation with us. Now, I've also seen some figures as I'm reading through, getting ready for this conversation, but as a concerned South African, I've also seen that a private sector has actually been analyzing or suggesting that if the national health insurance were to match the current level of private healthcare services across the entire population of South Africa, could actually cost up to 1.3 trillion annually. I don't know, maybe the figure is, for me, is quite high. Maybe just your comment on that, Prof.
No, it's nowhere near. It's more than double what would be at the end game. So what they've done, and to be fair to the people who published that, they were quoted out of context. They were very careful to say that they had just taken the total cost of a private sector patient and multiplied by 63 million. Now that, you definitely can't do that, because I've already explained that there's massive costs involved with the multi-payer system. So it's 21 billion rand a year is spent on administration before you even start caring for patients. That must be removed from the equation as an efficiency. Then, because of that complex system, the private sector tells us there's about 30 billion rand a year fraud in the private sector. So you need to remove that cost, because once you're running one system, there's no need for the fraud and waste and abuse anymore, because everybody knows what they are getting. So you remove a huge portion of that. Thirdly, because of the structure of the private sector, it opens itself for what we call perverse incentives. And it means that the providers, doctors, hospitals, etc., are basically paid to provide more. So whether you need the healthcare or not, you get it. And in economics terms, we call it supplier-induced demand. So I, as the healthcare provider, decide what you need. You don't have the knowledge. There's what we call an asymmetry of information. And I provide you with that healthcare whether you need it or not. So we have a ridiculous situation where 72% of all deliveries done in the private sector are cesarean sections. That's 3 times higher than it should be. We also see all kinds of other surgical procedures. We see patients going to specialists when they don't need to. So there are many problems with using the private sector figure and multiplying it by 62 million. Secondly, the health system should be built on preventing healthcare, not treating you when you've already got a condition. You should never get the diabetes. You should never get the hypertension. You should never get a stage 2 carcinoma of the cervix. You should never get immunization preventable diseases if the primary healthcare system is working. But the private sector does not have a primary healthcare system. They have GPs, competent GPs, who have been reduced to post offices by the structure of the system. We need to put those people back in control of the initial intervention of our care to look after us. So there are many savings. Let's not even talk about the public sector, where everybody knows about the fraud and corruption and the need to tighten the way in which we spend money and improve the efficiencies in the public sector. And that's part of what the National Health Insurance Act does. It says we shouldn't duplicate everything 9 times, each province do their own thing. We should have one national system. People seem to assume the Minister of Health at the moment controls the health system. That couldn't be further from the truth. It's 9 provinces who control their own health systems. Some are more efficient than others, and some are really struggling.
And speaking about those 9 provinces, Prof earlier mentioned the health system having to also be about wellness, meaning that you don't have to go to a clinic when you are sick. And I fully understand that, because right here in Gauteng, we saw the department being changed from the Gauteng Department of Health to Gauteng Department of Health and Wellness. Now, thank you so much for that, Prof. Let's speak about the money now. And this is probably the necessary conversation that we need to have now before the implementation. I saw the figure there, 1.4 billion that is going to be allocated or has been allocated over the next 3 years. I'm now confused. Has money already been allocated for the national health insurance? Let's speak about that.
So no money has been allocated to the National Health Insurance Fund, because there is no fund yet. So this is the way it's packaged and the way it is presented in both national budgets and in the public discourse is very misleading. First of all, when National Treasury gives a figure, it's 3 years, it's not 1 year. Secondly, you can put a label on anything. So the bulk of the money that's been spent on so-called national health insurance up to now, if you look at the detail of what it was spent on improving infrastructure. largely on the building of the big new teaching hospital in Polokwane. That's the major expense in that money. So the National Health Insurance is there to buy health services. There is no National Health Insurance Fund yet. There's no board yet. There's no structure that's in place. Therefore, there's been no money that goes through the fund yet. So, there's nothing like that. Of course, there's some money that's allocated to the National Department now that pays my salary and my staff salary as we plan, but it's peanuts compared with what's going to go through the fund in the end.
Will you say that is maybe what is causing the confusion? That people believe that there is already money allocated while that money is not actually allocated for the national health insurance, as you mentioned. So maybe the way this is communicated to the general public is what is currently causing confusion as far as the NHI is concerned.
Yeah, James, it's deliberate politics. Have a look at who is complaining and what they are saying. So the people who don't want the change, who don't want the reforms, who don't approve of the single-payer fund that we are intending to create through the legislation, they will try to discredit and say, look, you've already messed up. How can you mess up? How can the fund mess up when it doesn't exist yet? And how can the department spend on something that is the mandate of the fund, which isn't created yet? So it's very, very deliberate disinformation, and I welcome the opportunity to tell the public any money that's been spent on so-called national health insurance now has either been spent on infrastructure or on the development of the digital systems that will be necessary in the NHI, or on putting the quality control mechanisms in place. But nothing has been spent on the actual NHI yet.
Yeah, quite interesting that you are speaking about those who are against it. And I'm just reminded of the constitutional rights, including also legal challenges, which is another conversation I want us to have, Prof. Let's speak about that now. Some of the legal challenges I have seen on different media platforms, speaking about the constitutional violations, they are also they are concerned rather about Section 27, which is a right to access to healthcare, something that we have been speaking about, particularly of an ordinary South African. So how does the NHI address the constitutional concerns that people have, especially some of these organizations and individuals who have actually been challenging this? How do you as the National Health Insurance make sure that you get to clarify some of these issues and address these constitutional concerns that people have?
Yeah, so James, look, the problem is that we have this massive diversity in our country and this huge dichotomy. We have the worst inequity of all countries in the world, according to the measures that we see from the World Bank and the World Health Organization and other big organizations. So we have people who do not have proper access to healthcare. Theoretically, everybody has access to healthcare. The state will care for you. But in practice, if you don't have the resources to provide that healthcare, you don't have access to that healthcare. And even for poor people to drive, to get a taxi, to walk, to go to a health facility, to go and sit in a long queue, they don't, although in theory they've got access to that health service, they don't. They get referred from a clinic to a hospital. But how do they get to the hospital for that ongoing care? What do they do with their children? What do they do with their ongoing life while they've got to go for their health care? So access is not easy for those who don't have resources. On the other hand, we have people who have access that is better than you would get in a first world country, the UK, the US, anywhere else. Anything that opens and shuts is accessible to them. Yes, they pay for it, but the resources are there. Whether they need that healthcare or not, as I said just now, it's available to them. So now the challenges in the court is, you are going to take away my current access to the privilege that I have. That's the fight.
I see.
And you are going to make the resources that are available to me as a privileged person available, you're going to spread them. And you're going to make them available to the person who's poor. Well, that's not what the fund says. The Act says that the fund is going to make us all have equal access to a package of care, and we'll discuss comprehensiveness in a moment, to this package of care, and the Act is very careful to say that it will be based on available resources. And that means that if you want and can afford something beyond that package, that you pay for separately on your own. So it's still denying that fancy stuff. And I don't want to pick on anything specific, but there's quite a lot that medical science and technology can provide that you don't necessarily need. So that is the debate from this group of people. Now, I want to talk about the word comprehensiveness.
Yes, please.
Because those who are fighting with us say that what you currently get paid for in the private sector, if you are a medical scheme member, is comprehensive. Mm-hmm. Well, if you're amongst the 35% of people who are on a hospital plan, you get nowhere near comprehensive health care. Your primary health care services with your GP are not paid for. Your out-of-hospital examinations and special investigations, x-rays, blood tests are not paid for. Your medicines are not paid for. When you come out of the hospital where you've been covered by your medical aid, you pay for your physiotherapy, you pay for your medicines, you pay for everything. It's only for a small number of conditions called prescribed minimum benefits that you might be covered, and you may also not be covered. It's a small number of that 9.1 million on medical scheme who have what is labeled by the scheme's comprehensive cover. Mm-hmm. Even that's not completely comprehensive. Yeah. But the Act does not define comprehensive like that. The Act says that comprehensive means that the fund must cover the life course spectrum of healthcare from prevention and promotion through curative, through rehabilitative to palliative care. Mm-hmm. So the fund cannot decide that we are not going to provide any rehab or any palliation.
I see.
It must include, in order to be comprehensive, it must include those. Yeah. But what it includes might be quite small in the beginning, depending on what is the financial resource availability. Yeah. So we can argue about words, but they are defined in the law.
Yeah, absolutely. And I've listened to you there, and it is quite comprehensive indeed, Prof. Now, let's speak about, I understand that some of these legal challenges are currently, of course, the concerns that people have, or some of the legal challenges that people have decided to continue with are currently sub judice. But maybe let's speak about without commenting on the merits, I understand. Let's speak about some of the challenges that are brought by Solidarity, including also the Western Cape government and others. I'm just mentioning some of those that I remember now. What are some of the concerns that they are really raising? I understand what you said earlier, but maybe you want to add on to some of the challenges that they've been raising to say, we are against the National Health Insurance Act implementation because. What are some of those reasons they are giving?
Okay, so James, if you don't want the reform, you must go and scratch for every possible reason to make a case, and you hope that one of those reasons sticks. So that's what's happened with the applicants to court. They've complained about everything. Parties in the private sector who have nothing to do with the provincial administrations have complained that this impinges on provincial rights. Why are they worried about it? This is not explained in their court papers, but they've just said this impinges on provincial rights. We'll argue that when we get to court. Yeah. Other parties, like the Western Cape government, have argued that there was inadequate consultation or inappropriate or not thorough consultation. And they have argued that even the 60 meetings that the NCOP had during the period between the passing of the bill by the National Assembly and it being tabled at the National Council of Provinces, they've argued that the government and the department had no intention to listen to the public anyway. Well, they will have to make their case about that. I was party to some of those meetings. My staff went to every single one of those meetings. The overwhelming view of people who spoke from the floor was that they want the national health insurance. There's a small group of people who came and read their statement every time who don't want the national health insurance. And we're glad they came. It's their right to make that statement. They said nothing new that we hadn't already heard for the past 20 years. So whether you were consulted or not, people seem to think if we didn't agree with something, or if the government, the parliament didn't agree, because ultimately parliament passes legislation, not the department. Yeah. If parliament did not agree with your particular view, then you weren't consulted. That's not how consultation works. People had ample opportunity, made repeated submissions over and over again, and they were what they want to see changed or not changed, because mostly it's about maintaining the status quo, was not adopted and not incorporated. That's not to say there isn't room for improvement. Any piece of legislation can be improved, and that's Parliament's prerogative to do that in the future.
Yeah, because when I had a conversation with the head of legal at South African Medical Association, I posed the same question as to whether you consulted, they feel that they were actually given time rather to share their views. And you mentioned that yes, that was done, but they believe that they were not taken into consideration, or their views, so to say, were not taken into consideration. So will you say you are satisfied that yes, indeed, each and every person who was there, each and every organization was taken into consideration before the final decision was taken?
So from the department side, remember I'm an official, I work in the department. We get asked by Parliament to comment on what has been presented to Parliament. Parliament is the elected representatives of the people, and ultimately Parliament decides. And there's a process of committees and others. They ask us for our opinion. Remember, the department tabled the original bill. We tabled a bill from the department that said we want a single-payer system. Anybody who came up after that said they don't want a single-payer system would have to explain to Parliament why having a multi-payer system and parallel health systems and having inequity and not going for a universal system is better. The department would not agree with that. So we heard them. We also heard many different groups, physiotherapists, doctors, specialists, cardiologists, coming and representing their own particular group, saying we don't see ourselves in the bill. They are in the bill. The definition of a provider is very wide. If you are a professional and you are delivering a healthcare service, you are defined into the bill. In fact, the bill, now an act, describes a provider and a public provider and a private provider separately. So if you can't read yourself into that definition, there's no ways that a piece of legislation is going to say and cardiologists and pulmonologists and physiotherapists and. So those are the kinds of things that people have argued with us. But to say we didn't hear them, we could probably tell you exactly what each party said. There were 117 different PowerPoint presentations that I went through, and then there were all the other submissions that were made orally where we took notes. Those have been submitted now to court as part of the court record. So being consulted and being agreed with are not the same thing.
I hear you. And I wonder, Prof, as we speak about that, this particular legal or these legal challenges that we are speaking about, are they directed at the National Health Insurance Fund, perhaps at the Department of Health, or maybe both? Who is actually being, or who are these legal challenges directed at?
So, James, they're different, but mostly they are at the President first, then at the National Minister of Health, the Director General of Health, the National Treasury, and the Minister of Finance. They are the main respondents. But the last two cases also have, the last one has 23 respondents. Each of the legislatures, both the National Council of Provinces and the National Assembly, the speakers have been cited, the head of the legislatures in each province, all the MECs. It's a wide range of people who have been cited with various accusations leveled against them. Of course, each of those parties now needs to get legal representation, coordinate their representation, and decide whether they are going to oppose or not oppose the cases made against them.
Does it mean that we are not going to see the implementation of the National Health Insurance anytime soon with these challenges that we have?
So in terms of the legal challenges, unless there's an interdict from the court, there's no, the parties can't stop the implementation of the National Health Insurance. But it's in the interest of the public and the reforms that we hear what people have had to say. So in the first instance, the cases that have gone directly to the Constitutional Court will be heard first. That's what we are asking for. We are asking that the cases that have gone to the High Court wait until we've got an outcome of the Constitutional Court. Now, the parties don't like that. They want to argue one by one, bit by bit, so that they can chase us around and keep us busy, that we don't do anything else. That hearing is in February next year, I think the 24th and 25th of February, where we will argue our case about why the cases should be what's called consolidated, so managed together at the same time in the same court. And we will also argue why the current cases should be held in abeyance or stayed until the Constitutional Court has ruled on the constitutionality of the cases that are there. Now, the opposition wouldn't like that. They would like us to proceed with the remaining cases. In the meantime, the President can proclaim any one of the sections or all of the Act into law, at the request of the Minister of Health so that we can proceed with the various steps to create the national health insurance.
Yeah.
Remember, this is not going to be an event. This is going to be a long process. Countries that we've spoken to have taken anything between 15 and 50 years to implement their national health insurances. We will be no different, so we have to embark on the process.
Yeah. It is a long process indeed, as Prof mentioned there. We are in conversation with Professor Nicholas Crisp, and we thank you so much for watching this conversation, but also sharing it with others. We are Timia Africa on YouTube, including also other social media platforms. Like and share with others.